Welcome to Session 2 of Rhythm Interventions Online. I'm Dr. Devi Nair, and I'm delighted to be joined today by a fantastic panel for this session. We have Dr. Bradley Knight, Director of Cardiac Electrophysiology at Northwestern. He's also the Chester C. and Deborah M. Cooley Distinguished Professor of Cardiology at Northwestern University. Dr. Vivek Reddy, Director of Cardiac Arrhythmia Services at the Mount Sinai Hospital and the Mount Sinai Health System. Dr. Andrea Russo, Director of Electrophysiology and Arrhythmia Services, Cooper University Healthcare, and Professor of Medicine, Cooper Medical School of Rowan University. This session will be a live case on leadless pacing to achieve AV synchrony by Professor Schilling at Barts in London. I'd like to remind our audience today that this is an interactive session, so please feel free to submit questions throughout the session, and hopefully we'll try to address most of them. I'd now like to hand you over to our live case center in St. Barts in London.
Hello everyone, and welcome to Barts Heart Centre in London. Thanks for joining us for this leadless pacemaker implant. My name is Richard Schilling, and I've got a fantastic team around me looking after me and making sure I behave myself. During the case, I'm going to try and ignore the fact that the faculty is much more qualified and eminent than I am, and think about the audience and make sure that I'm giving you as much tips and tricks as I can that may be helpful in your practice or learning. This lovely 76-year-old lady has atrial fibrillation, so the first thing I've got to put my hands up to is that the title of the talk is misleading, because of course she's having micra because she's going to have an AV node ablation, so we're not going to synchronize her AV. She's had 2 previous ablations, and these have eventually failed, and she's elected, because she finds the heart rate control medication so unpleasant, to opt for a pacemaker and AV node ablation. And she's quite small and has specifically requested a leadless pacemaker, firstly, hopefully to reduce her risk of any lead complications, but also she's quite slim, and the pacemaker might have been quite uncomfortable in her chest. Before we start, I just wanted to show you a couple of echo images just to help the audience understand what we might be up to. And if we can play the echo images. Now, the first thing that you'll realize is that I am not a good echocardiographer, and these are my images, so I can't blame anyone else. But on this first image, you can see the short axis LV view as I move from the mid LV to the aortic valve, or the aortic root. And what you can see is just above and to the left of that LV, the right ventricle starts about halfway up the ventricle, halfway up the left ventricle, and is kind of stuck on the side. So the septum of the left ventricle bulges into the right ventricle. And then, Anna, if we go to the next image, please. And then in the long axis, again, you can see the left ventricle dominates. It controls the shape of the chambers, and the right ventricle on the left-hand side of this image is kind of strapped on the side. And what we're aiming to do is to get the micra onto the septum, probably near that moderator band, and the challenge will be is trying to get the micra through the tricuspid valve and then turned onto the septum so it catches on that septum when the septum itself is kind of concave and slides away from the micra. So sometimes it can take a little bit of fiddling around to get the micra into the best position. I'm now going to start actually putting the local anesthetic in. This lady's under sedation. She has a self-admitted 0 pain threshold, and when I put the Venflon drip in earlier on, she squealed. So I just wanted to show the trainees a trick that my dentist taught me. I don't know whether we can go to the other camera. So the trick here is, once you're happy that you know where you're going, is to just put the local in with a small needle and just do it very, very slowly initially, because the local itself has a little bit of acid in it that can be uncomfortable. And if you do it very slowly, the patient will not necessarily notice that. Once you've got a bit in, then you can be a bit more liberal. And I'm putting in quite a lot across the skin because I'm planning to use a Z suture at the end. So I'm making sure I'm covering that area before I put some more local in deeper. And by just being really patient and putting it in very slowly, she's tolerated that very well. The next thing I'm going to do is to use the ultrasound to gain venous access. So Anna's just going to switch us over, because as we all know, the risk of a femoral problem is much reduced by using ultrasound. I'm initially going to make my incision well medial of the artery, because I want to make sure that if I do come into a vein that's underneath the artery, I'm coming at it from the side that way, so I can avoid the artery itself. So if you go to venous and then press scan, press on the bottom left-hand corner there, that's it. That'll get us. So cancel that. As with all of these things, we've tested ahead of time, and then it stops working during the actual case.
Hi, Richard. It's Vivek Reddy, just watching you. First of all, beautiful imaging. I got to tell you, your cameramen are great. But a quick question for you. How often do you use figure of 8 versus suture? So I have colleagues who like to use, pre-close or one of these other approaches. We tend to use figure of 8 most often, but have you played around with different approaches?
I use the figure of 8, the Z suture. I did use the ProGlide for a while, but it's quite expensive, and I think it's quite difficult to use, particularly in the vein, because you've got to get, as you probably know, as I'm sure you know, you've got to get just the right amount of tension. If you pull it too tight, then it just tears the vein. And so I found that I was just not getting as good a results as with a simple Z suture, and it's a lot cheaper to use a Z suture. So I'm just pre-dilating with a 12 French sheath, just making sure that she's comfortable. I used the local... Can we go to camera 2, please? Guys, can we switch camera?
Richard, what kind of anesthesia do you use routinely for your leadless cases?
So this lovely lady's just having some midazolam and diamorphine. Okay, so can we just screen at the heart, please, and I'll just have the pedals. So we've given her 2 milligrams of midazolam and 2 milligrams of diamorphine. Okay, 3 midazolam and 2 diamorphine. I'm just checking the position of the wire is in the right atrium. This is a tough groin because of the previous AF ablations, so I'm just going to be fairly sort of generous with the sheath to make sure I've got that nice and dealt with. I've got a normal guide wire in there. Some people advocate using the super stiff, but I find that sort of hyper straightens the veins and makes the sheath harder to get up rather than easier, so I just use a normal guide wire. If we come on to camera 1, I'll move the sheath out. So this is a big sheath, which requires quite a lot of flushing. So my other top tip is I just put a saline bag on pressure up with a 3-way tap to control the flow. So rather than flushing this with syringes, I'm just going to flush it with this. the sheath itself has quite a good hydrophilic coating, and if you get it wet, it's almost impossible to handle. So as soon as I've flushed it, I'm going to turn it off and try and keep the sheath itself dry. So that's the sheath flushed.
Just out of curiosity. Can you also comment on anticoagulation? Patient, I assume, is in atrial fibrillation. Can you comment if you're doing this on anticoagulation or off?
We do this on anticoagulation, yeah. So we're happy to do this on a novel oral anticoagulant. Can I have the device, please?
Oh, sorry, go ahead.
No, you go ahead, Vivek.
Dr. Knight, do you use this technology in specific patient populations, or is there patients that you avoid this technology?
I don't think there's anyone we would avoid it. As Vivek said, we have a big renal population in London, in Barts, and so it's really helpful for patients who are on dialysis who've lost most of their vasculature. The population I find tricky are those that have got right heart problems or have had tricuspid valve repair, not because it's difficult to get through the valve, but because the right atrium's really dilated and the sheath may not come through the valve very easily. It won't deflect enough. Here's the device, so we'll go over to the other, and just to show you the various handles, we have a deployment lever here and a deflection handle here, and then we have a thread which loops around the little hole at the end of the device. So as long as that loop's intact, you're holding onto the device. And this loop can be locked, which shuts off this port here, but when you're deploying the device, you have to remember to open that so that the device will slide out of the sheath. And the first thing we're going to do is to flush the sheath and the device. I tend to do this all in the packet because it's just easier to handle the device. And you can see already we've got some saline coming through. Let me just move that so you can... So there's the saline coming through, and you can just about see the saline filling up, and there's no bubbles there. So I'm now going to recover this device into the chamber, and so that's now ready to deploy. Let me just quickly show you the tines. So here's the tines that Vivek was describing earlier on. And if you imagine, I'm glad I didn't have my coffee this morning, otherwise you guys would see my tremor. But if I pull it back in, if you imagine this is what happens when you're in good contact with the myocardium. As you push it out, those tines will come out and grab the myocardium and hold on. And what we'll be looking for when we deploy it is that 2 of those tines will move back when we tug it, which means that at least 2 are into the myocardium. I'm just going to give it another flush because I've pushed it in and out a couple of times without the saline running. So I just want to make sure that I've got that full of saline before I put it in. So you can, again, you see that chamber filling up. I'm going to pull it back into the chamber, and then we're good to go. Now, the first challenge is going to be getting this big sheath.
What are your thoughts about where Dr. Schilling's going to go for his implant site? And are there specific patient characteristics that you think could be a challenge during the microimplant?
I was going to raise the issue of tricuspid valve disease. We see patients who are now enrolled in trials where they're getting percutaneous tricuspid valve replacement, often patients who have a right ventricular lead, which we've seen one case dislodge. And so the question would be, are you comfortable placing this sheath across a recent percutaneous tricuspid valve or a recent surgical tricuspid valve repair?
So
Dr. Russo, Dr. Reddy?
Some of our surgeons...
Yeah. So in addition, to that, I would wonder if there's, certain locations, if you're planning a more septal location, and if that's more challenging. For example, and what Brad was asking is if they have had recent surgery, or if they have severe pulmonary hypertension and a lot of changes in the RV with dilatation, or some baseline TR if they didn't have a repair. What kind of other challenges do you face when you're actually making that decision on where to place the device?
And Dr. Reddy shared with us earlier how the septal location is so much important than apical location.
Yeah, I think to Brad's question, which is a really important one, I mean, we personally have no experience after percutaneous tricuspid valves, but after surgical valves, certainly we've done that. And again, I don't think the experience is very high, just the world experience. But at least so far, we haven't seen any issues. But certainly, I think Brad's point is a good one. There could be problems if one isn't careful, or even if one is careful.
I also worry about the ability to
So
track the
Schilling,
atrium after tricuspid valve procedure.
I'm sorry, Brad, say that again.
Is that-
The ability to track what?
When patients get heart block and you're putting in an AV micro, I don't know if there's a lot of data on the ability for the device to detect atrial contraction after they've had tricuspid valve surgery or one of these valves. That makes me a little suspicious it'll work.
Yeah, I bet there isn't. And I would also worry that when you start having these kind of patients, they probably have a lot of atriomechanical dysfunction too. So my guess is that their A4 signal is probably going to end up being low. But I don't think there's certainly nothing published on this. I'm not aware of any of such data.
Honestly, a lot of these patients, we've just put the lead in the coronary sinus, which is a very straightforward approach in the valve patients.
So Vivek, I think you've had some experience. We obviously only have one approved in the United States, but would you choose, if someone had tricuspid regurg or a recent valve, would you choose a shorter device or a longer, the alternative device that's a little bit longer and might reach towards the valve more, or not choose that one?
Yeah, no, it's a good question. Look, at this point, as you said, we only have one option, so it's an easy choice. But hopefully soon we'll have more than one choice. I can tell you when we use the thinner, longer device, yes, sometimes the back end would get close to the valve, but we've never seen a problem actually interacting, at least that I'm aware of. But having said that, certainly if you start having subvalvular apparatus related to the procedure, I can imagine that could be an issue. It is interesting, though, that the next version of that nanostim device is actually going to be a little bit shorter. Oh, sorry.
That's good.
So any specific echo criteria that you look for your micro AV patients?
Do you look for E and
Yeah,
A?
that's a great point. Sorry, Andre, go ahead.
No, I was just curious. I think you probably have the largest amount of experience, you and Brad and Richard. But do you pre-screen with echoes to see what their any A waves, what the signals are gonna? Do you anticipate anything, or you just try it and think, well, 80% or so synchrony will be good?
I mean, I think that if a patient, if you really want AV synchrony in a patient, and you're really trying to decide between a leadless and non-leadless, I think it does make sense to get an echo and look at the E to A ratio, because the data is pretty good that when you have a low E to A ratio, less than 0.93, well, less than 1, let's just say, then your chance of having a very high rate of AV synchrony is actually quite good, greater than 90%. As opposed to, let's say the EDA ratio is greater than 2, then your chance is like close to 0. So in general, we haven't been doing it, but I think in those kind of patients, I think it actually makes a lot of sense.
I think we should get back to Professor Schilling. I think he's waiting to get the sheath in.
Yeah, he's got to do it in 20 minutes, remember.
I was born ready, Devi. So look, once I've got the sheath up and the device in, I'm going to move pretty quickly because I'm always a bit uncomfortable about leaving it sitting in the circulation, collecting thrombus. So if we can show camera 2, I haven't done anything yet. I've just literally got the sheath through that little tough bit in the femoral. I've already screened the wire on the X-ray, so if we can show the X-ray as well as the video on the live screen. So if we can put the X-ray in as an inset and the camera, that's it, perfect. So you can see there's the wire in the SVC. Now what I want to do is to get the dilator of the wire, the dilator of the sheath up the SVC, because the sheath is quite a way back. Sorry, my love, this may be a bit uncomfortable. This is the uncomfortable bit. Can you hold on to that for me? Thanks. I want to get the sheath in the mid-RA because I don't want to advance the device out of the sheath and while it's in the IVC. So I want it to be in the RA. So that's the dilator out. The pacing, the device itself has a little black marker on it here, which tells me when the device is at the tip of the sheath. So I'm not going to screen until I've got it to there. And then I'm going to do a little bit of combination of pulling the sheath back slightly and advancing the pacing wire, pacemaker out to deploy it in the right atrium. And then deflect it through the valve. And we'll head over towards the apex when we get there. So can we get to the apex there, please? And go REO there for me, please. So we've got ventricular ectopics. Now I've released the bend on the sheath, but I think it's a little bit too superior. I liked it to be slightly more mid-septal, so I'm going to try for a slightly lower position. And then if I release the bend and the lead doesn't straighten, then I know I'm caught on the septum. Can we go LEO, please? And I'm trying to develop enough pressure to have a bit of a gooseneck on that sheath, but not push too hard that I cause it to wobble through. So that's the LAO view. Back to REO, please. And I'm going to just deploy now. And I'm just going to release the lock. And then we're going to go on to a zoom view at 15 frames a second so that we can look at the tines and see whether they're caught. So just centering up, and then I'm just going to acquire this at 15 frames a second, tugging the device back. So I can see at least one of them moving. We'll go to the LAO view. So you can see one of them is straightening out as I pull it back. So I know at least one of the tines is caught. And I'll just give us a little look to see whether they're centered up. Just come over a little bit more just to get that lung flare off. Okay, let's see whether we can see anything there. We may need to try a much steeper view. Okay, so I've only done one tug there, but I can see two of them moving, so I'm happy. We'll go back to AP view, please. And now we're going to test the threshold, which I find a really, really good way of knowing whether it's well fixed, because if you don't have a good threshold, it's probably not fixed properly. But really, the meat of the procedure is now done, and we're just going to test the threshold. Can we show the programmer on one of the insets so we can get rid of my hands? And okay, so we're just going to interrogate. So we've got telemetry.
Did not give contrast. Is that something you've not done since the early times?
I've stopped doing that now because if it stops, I know it's in contact, and the gooseneck tells me that I'm in contact. So I've stopped giving contrast now. It just adds an extra bit to the procedure. Guys, do you want to just keep telling me what's going on over there?
Is
the
there
R wave is
So do any of the
19.
panelists go to steep LAO? So do any of the panelists actually go to a steep LAO position for visualizing the apex, since we saw some recent publications on it?
I tend not to. So first of all, I think what Richard's done is really nice. It's beautiful. It again highlights why leadless pacing is so much nicer than doing a transvenous device where you're straddling the fluoro. I do things a little bit differently. First of all, I just want to highlight what Richard said, which is really important. As you come into the right atrium, you want to do a combination of advancing and retracting the sheath, because when it first comes out, it's really quite stiff. So I think that was really a key thing that he pointed out. But the other thing is, I do tend to use a contrast injection, not so much to know that I'm touching the tissue, but more to see where in the septum I am in an RAO view, to see if I'm, toward the free wall. And I guess part of the reason I tend to do that is because I guess just watching Richard, it's actually nice to see different people do it, because I use a lot more pressure up against the septum before I deploy the device. And that's just the way I've always done it. And I guess it's nice to see Richard do this, because perhaps I'm overdoing it. But one of the issues is when you put a lot of pressure, there's a tendency for the catheter to slip across the septum and go more toward the free wall. And I will do everything I can to avoid a free wall one, just to avoid complications.
Well, I agree with what you just said. I tend to try to create a much more of a gooseneck than that. And then as you deploy the device, you have to be a little bit careful you don't topple it over. We don't have nearly the experience I think you have, but we still give contrast. And one caveat there, as I've seen the device be deployed during the injection of contrast, so you have to be a little careful about administering the contrast.
Take off the programmer. Can we take away guys, can you take away the programmer? So guys, so just to comment on that, so I would say
it is
that
important to use half and half.
I'm
Especially
a bit
when
of
you're
a
using
wimp with the
contrast shots,
pressure.
and I think we use a lot more contrast shots than the Europe does.
But it's nice to know that there's different
So
ways
guys,
of
I'm just
maybe
going to recover this.
without contrast if someone has allergies.
So sorry guys, I'm just going to recover this so I'm not hanging around. So I've just checked the thread runs both ways easily. This is the thread that goes through the loop of the device. I've cut one of them and I'm going to pull it through now to release the device. We've seen that the R wave is 19. The threshold is 1 at 0.25, and the impedance is 900. So we're happy with that. So forgive me for butting in. I would say that probably about 30% of my patients I would have to reposition, because I'm a bit of a wimp in terms of the pressure I put on. The other thing that you guys will know is that if you also try and clock it too much towards the septum, it does what you would expect with a multipolar catheter and flip up into the outflow tract. So there's a sort of balance of the amount of torque you put on and pressure you put on, which I've found that the Medtronic training program is really good. So I found that my learning curve wasn't that long, just because their training program's so good. I'm just really slowly pulling this thread back with the loose fingers, so that if there's any resistance, it slides through my fingers, because I don't want to disrupt that device. Once you've got through the loop at the end of the device, suddenly the thread becomes easier to pull back. I'd be interested in the panel's tips and tricks, as if the thread gets stuck. What do you guys do?
Yeah, I think that's a really good point, Richard. Because Medtronic, they did change their catheter, right? So initially they had separate lumens for both of those wires, and then at some point they changed it. So we suddenly had the situation where we ended up getting stuck. Now, having said that, there are workarounds. You simply have to make sure that when you're doing this, the catheter is not too high up, so it's sort of at the same level of the device, or a little bit lower. And number two, you don't want to inject after you cut it, because that tends to cause the sutures to bunch up more distally. So it's actually sort of counterintuitive. You inject before you cut it, and then once you cut it, then you just slowly withdraw. Using that approach, we haven't had a problem, though. I do remember the 1 or 2 cases we had in the very beginning when this problem was first occurring.
contrast, it's important.
So if we show the inset
Richard, we
X-ray,
have a
guys.
question from the audience. For you, so are you planning an AV node RF right after the implant?
No, I'm going to leave it 2 weeks to make sure everything's okay before I do that.
How far away do you like the sheath to be before
So-
you
About
pull
the
them?
panel,
Tug
do you
them.
guys, do you do concomitant procedures?
It's interesting when you ask, even
So does the
you know,
panel
years
do-
ago, when we used to even we first started doing AV junction ablation, talking many years ago, in the 1990 or so, we used to wait. The routine thing was to wait until you felt, everything was stable, even though, dislodgement rates would be extremely low. I actually like the waiting. I mean, depending on how acute the situation it is. Certainly no one could ever fault you for waiting. The patients probably had rapid rates in AFib for many weeks or months. So I actually like the waiting. That's what I typically recommend, but I know a lot of people do at the same time.
We use.
Yeah, I mean,
we
in the
use multiple
clinical-
science. Go ahead.
Sorry, go ahead. No, I was just going to say that in the clinical trials with both nanostem and with micro, there were a number of cases that were done. I can't remember the number exactly, but there were a lot of cases that were done with concomitant ablation and leadless implant. And in our practice, we tend to do them simultaneously. I mean, I agree with you. Waiting makes, waiting is certainly much more comfortable, but our patients like to have everything done, as I'm sure most patients do. And when we do that, I'm just much more, I don't know if careful is the right word, but much more aggressive with my tug test and everything else to really make sure that this thing is not going to dislodge.
Yeah, I would agree
I
with
have
that.
to say that
So I think we have a,
Go ahead.
go ahead, Dr. Knight.
Sorry, guys. I was just saying I would agree with that. There's not real logic to waiting with the micro because it just seems to be very stable. It doesn't. I've not come across one that's moved late after the procedure. So I must say I have sympathy with the panel that actually there's no logic to waiting. Just for the trainees, so I've done the Z suture. I'm using a 3-way tap, which allows me to then loosen it later on and walk the patient around and make sure they're okay. And if they're not, if they leak a bit, then we can just retighten it again. So that's us done now.
Can I make a comment? I really appreciated your initial comment about accessing the vein from a very medial approach. I try to harp to our fellows on that topic. If you use ultrasound to get access, it's very tempting to go straight down onto the vein, but if you're only looking at the lumen of the vessels, you don't recognize that the wall of the artery gets very close to the vein. So coming in very medially avoids some of the complications. Do you ever do a contrast injection of the iliac vein to make sure it's big enough? That was kind of recommended in the early days.
If that's a question to me, I just use the ultrasound and just as a matter of course try and take a medial attack at it. I don't look at anything beforehand, to be honest. I'm interested in what the rest of the audience, the panel say.
Yeah, I think, Brad, you're referring probably more to the iliac tortuosity potentially and further up. I don't do that routinely. There are some older patients, particularly if they have kyphosis, that I'll consider doing that, or scoliosis, that I'll consider doing that. The other thing is there are a couple of patients that we've had, and typically older patients, where, as you know, that angle between the IVC and the right atrium can sometimes be really acute, and you actually end up going into the hepatic branches over and over again. And in those situations, I found that injection of contrast can be helpful in terms of delineating that. In fact, I had one case. This is a while ago. One case where we had such difficulty entering the right atrium, we actually ended up going from above. So we put an SVC puncture and put a loop down to a snare to grab it and then to guide that across the junction into the right atrium. And I should point out, by the way, that you could also do it completely from above. There have been a number of cases that have been reported where you do an IJ from above and can implant the device.
poll for the audience, and we'll bring that up in a second. In the meantime, Dr. Schilling, is there any particular closure steps that the audience should keep an eye on? What is your discharge policy for your leadless pacing patients?
So pretty much the same as yours for AF, Devi, that we leave them with the suture in for an hour and a half or so. I have to give credit that the three-way tap idea was one I stole from you when I visited you. I was tying a knot before that, so I have to give you full credit for that. So we'll loosen the suture, the three-way tap after about an hour and a half, and if they can walk around without leaking, then we're very happy. And I teach them to do self-compression if they do have any problems when they get home. And it's unusual, but if they do have a problem, then they will usually be quite happy. They've just got to be patient, lying at home, pressing over the vein to prevent them getting a bruise if they do have another leak later. But it's pretty unusual that happens.
So I'm going to go ahead and read the poll question that we had. The question was, in 5 years' time, what proportion of pacing do you believe will be leadless? And we had the answers that we gave were 5%, 10%, 20%, and 50%, and 100%. And our audience thinks that 50% will be less than 10%, and about 33% might be less than 50%. We have 5% that think this 100% going to be leadless. So I think Richard, you did a phenomenal job implanting this leadless pacer in under 20 minutes. So for the panel, Dr. Reddy, where do you see us taking this technology in the next decade?
Well, I think the micro AV is the first step, right? I mean, as you know, a straight ventricular pacing, so VVIR gives you about 10 to 15, maybe 20% of the population, depending on what your practice is like, depending on where you are in the world. The AV, the ability to have VDD, so
the echo
pacing,
on the live stream,
gets you to almost 50% of patients. So I think that's pretty impressive. The problem with VDD, again, is that there's still some uncertainty, as Andrea brought up, in terms of having good AV synchrony. I think that some of the clinical predictors like EDA ratio may be good enough, and it may be that we'll be happy with this, but certainly Leadless is moving toward dual chamber pacing with devices communicating. And there's little doubt in my mind that it's going to work eventually. I feel pretty confident about it. And there's some questions in my mind in terms of safety of atrial fixation as opposed to ventricular fixation.
How do they come on?
But I think that's going to be a tractable issue.
Take them off.
The bigger problem is cost.
Over there.
I mean, when you start talking about two devices, suddenly the cost is going to increase. Though it's interesting in my mind, one of the things I learned is that a lot of the cost is actually the delivery tool. So if you can use the same delivery catheter for both devices, that apparently cuts the cost down quite a bit. But there's going to be no doubt that the cost is going to be an important issue.
Yeah, but Dr. said that Dr. Reddy brought up the cost of this technology, and it's been one of the biggest challenges in certain centers, especially in the U.S. What do you see that our audience can use as explaining to administration as some of the valuable aspects of this technology, and what has helped you take it to administration, if I may say that way?
Yeah, that's a great question. So when we first, came up to our center when we were with the micro device, we looked at our numbers of patients. Actually, that Vivek mentioned, 10 or 20%. Actually, only it was like 5% of our pacemakers were single chamber, because I think we were, put it at lead if you think you're myocardiovert, obviously the patient, they're not in permanent AFib. So at that point, we sold it by, it's only going to be 5% of what we were doing. But, obviously that was not going to be the case, and we just wanted to get it started. But it is, it is a device that some patients, for patients you're worried about, our dialysis patients we use pretty routinely, anyone who has potentially vascular access issues, it's something that you need to have, in your armamentarium of, therapies for patients. And it's patient care. Obviously we need to know more about, long-term retrieval and, things after the devices are in, 10 years or more. Those are the kind of things that'll limit in our younger patients, or right now with the algorithms for the VDD, devices, if they have, want to increase their heart rate, they exercise a lot, and it's not really made for sinus tachycardia, at rapid rates, and you're not going to assure AV synchrony right now. But I think it's going to continue. I think the algorithms will continue to improve, and the uptake will continue to improve over time. So just it's a necessary item for patient care, and in certain populations right now will benefit. We need to do it. We've done it after, extraction of systems in pacemaker-dependent patients. There's some data on that now, but we need it for patient care. So, and I think over time, I guess the costs may go down if there's, when there's competition in the marketplace. I suspect that'll be an issue, but I'm curious to hear what others think.
Wait, so can I ask all of you, Andrea, Brad, and Davey, what % of your dual chamber patients would you say are using the AV device in right now? And I'm not talking about the dialysis patients and the exceptional patients. I'm asking as routine type of care, what % would you say?
We're doing it very infrequently, but a topic we haven't raised yet is the need and interest in physiological pacing. I think that's the real obstacle for widespread adoption of, even if it were performed very well for AV synchronous pacing, I still think that there's a logical argument for physiological pacing that this doesn't achieve.
So guys, can I just jump in and just show you the echo images?
Yes.
And like you brought up before, things like EA ratio, and we've been doing routine echo screenings for our patients that go for micro AV. We actually look at atrial contraction excursion and EA ratios before we implant micro AVs, just so that we don't end up with a VVI device in the end. So we have a question for Dr. Schilling from the audience. They want to know, do you implant your micro AVs at any different place in the septum than your VVI device?
No, I try and get it into the mid-septum. So here I think you can see the echo images now. And again, this is me, so don't blame anyone else for the poor quality. But in the short axis view, you can see there's the ventricle, there's the tip of the device stuck on the septum there. And then as I go further down towards the apex, you can see the device is sort of mid-septum. And I'll go to an apical 4-chamber view. And again, you can, when I get that view lined up there, you can see the device stuck about 2/3 of the way down the septum, away from the apex, sort of hanging out. But for those patients who have prosthetic valves, you can see there's the tricuspid valve batting away, and that device is nowhere near that. So even putting it sort of relatively mid-septal, you can be pretty comfortable that that device is not going to impinge on the tricuspid valve. So I personally quite like it for that, although it's always a bit anxiety-provoking when you're putting it in someone that's just had a valve a couple of days old.
Really nice imaging, I have to say, as also a non-echocardiographer.
With a sonocyte, no less.
Yeah, exactly.
We end up using intracardiac echo for a lot of things. And what's the panel's thoughts on that? I know it's a straightforward procedure, and the goal is for us to keep it straightforward and simple. But do you feel like there are challenging situations in leadless cases that you might end up using more technology like intracardiac echo?
Yeah, I have to say, I have a low threshold for intracardiac echo. I mean, we don't use them routinely. We don't use them routinely in these cases, but particularly, for example, if we have a little old lady, particularly if they're on anticoagulation, I'll consider using ice in that patient. And all of the leadless extractions that we do, I like intracardiac echo. I think it's very useful there.
Stay tonight,
it's interesting, Vivian, you bring up the little old ladies. Those are even the ones with, RV pacing that we worry about with the, the older, thin ventricle, little old ladies. Curious to know if people have seen, or not seen, because you're putting the lead on the septum. Have you seen higher problem rate or frequency in little old ladies, or in any, women in general? And women always seem to have higher complication rates from a lot of different procedures, even transvenous devices. We have not, but I'm curious to see your thoughts.
Yeah, I think that everybody has really been appropriately instructed to really keep it on the septum. And I think because of that, there have not been, I'm not aware of any data sets where there's actually been a statistically significant difference. I'm sure that if you treated 1 million patients, there would be a difference with the little old ladies losing out. But having said that, I think that if one is really diligent about being on the septum, I feel very comfortable with it, even on anticoagulation.
Dr. Knight, your thoughts?
I think that it's important to screen patients in advance. So if it's a person you're really worried about that's quite frail and small and may have tortuous veins, we may not bring that patient in for a micra anyway. But yeah, I think all the points that are made are important. It's important to not put the device out into the true apex, but I do find that when you advance it, you may not hit the moderator band, and you may hit the junction of the RV free wall and the LV. And although it's not truly the apex, it still, I think, can be a thin area, kind of mid-anterior septum.
I think that's a very important point. It's not just the apex that's thin. It's potentially the whole RV free wall. So if you're not on the septum proper, and you're at that junction with the free wall, wherever that free wall is, then you have to recognize that and either make a decision that that's what you want to do or reposition.
But I think a device that could deflect the sheath in another angle would be helpful, because getting that angle can be difficult.
Yeah, I agree. I mean, they did do a...
Okay.
Go ahead, Dr.
Just on learning curve, I'm curious to know, as we're talking about fellowship training, there's not specific requirements right now, and I'm just curious what the rest of the panel thinks in terms of, a learning curve. In terms of, there is some data, I think it was with the nanostim device, with a larger number of devices before your adverse event rate goes down. At least initially with some of the data. What are people's thoughts, and what do you require for your fellows in training?
We haven't specifically addressed that issue. That's a good topic. I will say there's kind of two issues here. One is deploying the device and getting experience with that. But I think the first issue is vascular access and putting in large venous sheaths. And I think all of our trainees are getting more and more comfortable with that, whether it's with Watchman or cryo sheaths. And we're putting in a larger venous sheaths and using ultrasound guidance. But I don't have an idea of how many leadless pacemakers trainees should have before they start doing them. I don't think the learning curve is too much. I think really once you've done probably 5 cases, you're pretty comfortable with deploying the device.
Yeah, I tend to agree with Brad. I mean, we have not picked a formal number of what we consider adequate, though I guess now we probably should. I was going to say 10 as a nice round number. I would say somewhere between 5 and 10.
Sounds reasonable.
Okay. Richard, you ready for a summary? I think you're showing that you're done with the procedure and patient's probably leaving the room.
Yeah, our patient's on her way out. She's giving me a wave. So I think that, in summary, I think this is a fantastic therapy for patients that you can't get a conventional pacemaker in. I think there are some limitations. The AV tracking, particularly on exercise, the rates are limited to which it can get up to. I made the procedure look easy because it is easy. It's not through any skill of my own. And as the panel have said, the learning curve is pretty short when you do a good training program. So this was the procedure I wasn't stressed about doing a live case on. The one I did on Wednesday, I was. So thanks very much for all your input. It's a real honor to work for Rhythm AI, Rhythm Interventions Online, and for such an amazing panel.
Yeah, it was terrific. It was great.
I think
Dr. Schilling, you did a phenomenal job today. Just a quick question that came up from the audience about programming, especially micro AV. So any specific programming tips? And before you get to that, is there any specific threshold that you don't accept, or what's your kind of limit to that?
So if it's higher than 2, I will usually look for another place, knowing that unlike the rest of the panel, I don't push that hard, and often I don't push hard enough. It's worth, as you know, waiting, because sometimes the threshold will come down, particularly after a tug test. The threshold seems to rise a little bit. But anything below 2 at 0.25, I'm usually pretty happy with. In terms of programming the AV, we've only been putting them in for a month or so, I think, now. So we're still very much dependent on the company representatives to tell us how best to set that up. And in the UK, we're lucky enough to have cardiac physiologists who basically just specialize in devices. And frankly, they will often know a hell of a lot more about the device than I will. So I'm very much dependent on the representatives and the physiologists to do the fine-tuning of that programming.
Dr. Reddy, Dr. Knight, and Dr. Russo, any thoughts on post-programming tips on micro AV, since it can be sometimes challenging?
No, but it is an important topic. Our device nurses just asked me 2 days ago about this, because I think they struggle, and it's something that we do rely on the reps far more than we do other devices.
Yeah, we're in the same situation too. It's a learning curve for all of us, and we've only had a short experience. I've been involved just a handful of less than 5 cases now. So it's, I think, over time and formal. I think it's something that we as people who do education all the time should come up with a formal process for educating on how to program and troubleshoot. And I suspect somehow in the future, some of this will be more automated, but maybe not.
Yeah, I was just going to add to that
Dr.
I think
Reddy?
that for me oh, sorry.
Go ahead.
Oh, no, I was just going to say very quickly that
Go ahead, Dr.
for me,
Reddy.
the biggest question is whether or not to put in a micro AV or go with a dual chamber. And I think it's something that, the good news is that even if the patient, if you put it in and you have a problem with AV synchrony, you can always take it out and put a traditional device, though that's an expensive maneuver, let's say. But our experience is also very early at this point. So I don't know yet. We're still developing our strategy.
And we need more data in terms to how to better
That's a
screen,
great
and if
question.
it echoes or other screening.
So what % of your patients that you're doing the leadless technology is actually having to move to a transvenous device at this point?
Oh, none. I haven't done it. I'm just saying it can be done. So it's nice to have that option. That's all. Or were you asking because of dyssynchrony? Because there is a small % of patients.
Yes.
I mean, I think the point that Brad brought up earlier about the not physiologic pacing, to me, has still been the biggest downside of leadless pacing. Again, it's more of a theoretical downside for the majority of patients. Remember, it's a very small % that actually decompensate or even have any reduction in ejection fraction because of right ventricular pacing.
Or there may also be an increase in AFib
Dr.
if you're
Schilling?
VGuide pacing in the setting of even AV block. You may have some increase, incidence of atrial fibrillation. But I think the biggest limitation right now is a lot of patients have sick sinus syndrome, so you're not going to have that atrial pacing. So we don't have that yet, right? It's VDD. So and then trying to select in younger patients, obviously with sick sinus, you're thinking that you're going to have to replace. We're going to need a few devices over the lifetime. In a younger patient, they're more likely to have sinus tachycardia if they're active and have normal sinus node function. So I think there's some limitations. So it's not. We've been very selective. Again, we've only put in a handful so far. of the micro AV device, but I think it'll continue to increase.
But Andrea, I just want to point out it goes both ways.
So, Dr. Schilling, there's a
I agree with you
question.
on the one hand. Oh, sorry, just want to finish. On the one hand, I agree with you. A young patient, you're talking about multiple potential changes or additional devices over their lifetime. On the other hand, if you go the transvenous route, you're talking about a lifetime of lead issues. So I actually, I struggle with it, but I tend to go more toward the leadless when I get to my younger patients who could potentially tolerate a leadless device. Certainly the patients would rather have it.
Absolutely. Yeah, that people want it. That's for sure. So I think that it's just assuring ourselves that after 10 years, we'll be able to easily extract, I guess, is my only concern in a younger patient. If you have 2 or 3 of these in there, or 4, or you're down the line. But no, I share that. And I think leads are clearly the weakest link of our systems, our pacing systems, our ICD systems, for a lot of reasons. I agree with you.
So, Dr. Schilling, there's a question from the audience for you regarding your anticoagulation protocol during leadless pacing, pre, intra-op, and post.
So we use uninterrupted anticoagulation. We'd much rather have them on an oral anticoagulant than Clexane or heparin. So particularly for patients with prosthetic valves, we'll do this with uninterrupted anticoagulants. And as Vivek said, if you're really diligent about making sure you don't push until you're on the septum, then you should get away with that without too much trouble. The other point about the threshold, one of the things that's really important is that we try and get a low threshold because, of course, that will increase the longevity of the device, recognizing that there's only so many devices these patients can have. And so we try and aim for a projected 8 to 12-year longevity unless the patient's got some other reason that they've got a shorter lifespan. So that's another reason to really pursue a low threshold. And generally, you can get below 1 at 0.25 in most patients.
Great points. That brings us to the end of this live case session. I'd like to again thank Professor Schilling for a great case, wonderfully executed under 20 minutes, and also my thanks to our panel, Dr. Knight, Dr. Reddy, and Dr. Russo. The program sessions of Rhythm Interventions Online is now going to take a short break before session 3. But during the break, there are symposiums and breakout sessions that are highly educational. Let's take a look at what's coming up.